Dean Eckhart, she is here today, and my colleague and friend, Dr. Ghazala Makda, our one of the board members, Dr. Karthik Mani, always there for the webinar and looking after all the technical things. And I welcome Dr. Vasudev Savlani, also one of my colleagues. He is here today. And everybody, participants, welcome to this 11th webinar of International Chapter. And today's speaker is Dr. Kavita Arora, who is very well known in ABI area of pediatrics occupational therapy. And I heard about Dr. Arora from my colleague so much. So it's a pleasure to welcome Kavita. And I know you are basically raised and born and raised in Bombay, I believe, yeah. And you
Yes.
studied you did undergraduate, postgraduate in Mumbai, and Dr. Aurora completed PhD in applied biology, and she has a master's in occupational therapy, master's in physical therapy, and master's in behavior analysis therapy. So that's quite a combination of both the disciplines OT and PT and behavior analysis. So without further delay, I would like to hand over the mic to Dr. Kavita Arora. And it's a pleasure to welcome you, madam. And go ahead. Thank you.
Thank you, Karthik. Thank you, Vijay. Thank you, Gazala. Thank you, Anita. And to everybody that's here for giving me this opportunity to share my knowledge with our OT team. I always loved teaching and sharing my knowledge, and here I am. So, without much further delay, I want to use our time to the maximum. I am based in USA, and I did all my half of my education in India and half over here. And we run ABA program, and my clinic provides all services: OTPT, speech, ABA, nutrition services. In short, all services under one roof. This is the name of our clinics over here. I'm going to skip this. So what we want to do today is I want you all to walk away with some very simple techniques and strategies, know a little bit about what is ABA and what is the role of ABA in children with autism and other behavior issues, and how you can incorporate these simple principles in OT immediately as soon as you walk out and you go back into your work on Monday. So let's get into this very quickly. So let's talk about what is ABA. I know people, we are all highly educated and we know what is ABA. But just to sum it up in very few short sentences, ABA is basically, as the word says, behavior analysis. So it works to assess what the child is doing, whether it's he's having a tantrum or he's having aggressive behavior, or he is listening to you, or he's looking at you, or he's giving you eye contact, or he's doing an imitation activity, or he's doing communication. No matter what he's doing, that is all behavior. So whatever we are doing right now, we are all watching my presentation. That is a behavior. So you're looking at my presentation, you're listening to my presentation. It's all behavior. So an ABA person basically is qualified to look at what the behavior is, how the behavior is happening, how is it affected by the environment, and how the learning is taking place. So we understand all these situations. And if there are any issues going on, we come up with techniques and strategies on how to make this work or how to make it better. So, in short, ABA is all about bringing changes in our socially significant behaviors. And and don't take behaviors in a psychological sense. Psychology is very different. Behavior is all data driven, it's all objective, it's all scientific, it's all evidence based. So we are not, it's like OTPT and speech, like how we have come to that stage in OTPT and speech, that it's an evidence based therapy. There is no doubt about it that it works. We have tons of studies that have been published across the world. Same thing it is with ABA. It is a little bit newer than OTPT and speech, but it has passed through all those rigorous sciences, which make it a scientific and a medical necessity therapy in today's medical field. So it's also one of the most evidence-based therapies. As I said, it's data-driven. It's the core component of ABA. We don't talk in terms of, oh, the child is improving in eye contact. Oh, the child is improving in following directions. We prove it by taking data for every of those behaviors um, and show it that, yes, this person was having no eye contact with 0% from the beginning of session, and now he's giving me eye contact 100% of the time. So that is the very, very important key component of ABA, that it's very, very data driven, it's very scientific, and it's very objective, but it's also highly individualized and person centered, just like all our OTPT speech therapies are. So we analyze what behaviors we are seeing. As I said, I don't have eye contact. I don't respond to my name. I do not track objects, or I have excessive behaviors, which is I'm doing a lot of flapping, or I'm doing a lot of vocal stimming, or I engage in echolalia. So those are known as behavior excesses. So any of these things, I can take data on it, and then I start working on that data, on that skill, and start showing whether the child is making progress. If he's not making progress, what changes I need to make to get to our end result of bringing about a change or improvement in our clients. We also work on behavior rigidity, which means, our children with autism or anxiety or Asperger syndrome, whatever it is, they have some behavior rigidities. They have difficulties in transitioning. They are very picky eaters. They cannot accept deviations from their set routine. So these are the things that ABA therapists will also work on in terms of making changes to it, again, with proper data. And how environment makes a difference in the child's behavior. We all know that, sensory components make a big difference in our children's performance. Same thing, how behavior is affected by environment is a big, big thing, So we want to come up with a behavior plan which will address all of these deficits, whether it's behavior deficits, excesses, rigidity, environment, anything that's happening. We take into account all those things. We come up with a treatment plan, just like OTPTs and speech do, and then we set up the goals to work on these different deficits or behavior excesses or rigidity or environment to improve the child's performance. Okay. All right. So basically, this is what our goals are. You want to increase the behaviors that the child is wanting, is needing, which is, communication or requesting or eye contact or, listening. Or we want to decrease behaviors which are harmful or they affect learning, such as aggressive behaviors, throwing object, property destruction. So we work on all those behaviors as well. So just note that this is, we don't ever claim that we are going to cure a person, whether it's OTPT, speech, or ABA. We don't do that. We never use that terminology. We want to say our goal is to minimize a person's symptoms or to help them get better. But they do get better to the point that we have seen that they can lose the diagnosis of autism as well. And we've already talked about all these things. So these are all the areas in which ABA works: communication, language, attention, focus, memory, academics, social, play, adaptive skills, and community safety skills. And then we work on reducing any of the challenging behaviors that can be present in children: tantrums, aggression, property destruction, SIBs, which is self-injurious behaviors, non-compliance, transitional difficulties, academic refusals, and other behavior challenges. These are some of the research findings. You know, there was a very landmark study that was done in 1987 by Lovas in California, which was they provided intensive ABA therapy to children with autism for 2 years. And with using all ABA principles, it was very intensive ABA. And they found a gain of almost 37 IQ points. Now that's huge and phenomenal, but also remember that it's 40 hours per week. It wasn't 2 hours per week or 3 hours per week like OTs and PTs work, you know. So it was very, very intensive intervention that was provided with data taken at every minute of the day. And they showed that there was a significant gain in their IQ. And not only that, that these gains were maintained even when the therapy was discontinued after a period of 2 years. So we know that it works, and the important skills that we work on are maintained as well. Okay. These are just some of the statements that have been given by big public associations: American Psychological Association, American Academy of Pediatrics, CDC, New York Department of Health. Everybody has recommended that ABA or its principles can be included or should be included as a part of intervention for children with autism. And of course, it includes children with other behavior issues as well. Okay, so now let's jump into how we can use some of the ABA principles in our OT session. And as I said, my goal was to share some simple techniques and strategies with you all, not to bore you down with all the theoretical part of ABA, but to give you all some basic principles and strategies from here that you all can take with you all and say, oh, I can implement this on Monday, or this is the kid who would benefit from this type of strategy or from this type of method of intervention. So these are some of the strategies that we will talk today. What do we mean by preferred and non-preferred tasks? What's meant by preference assessment? What is meant by rapport and pairing? Behavior momentum, using token board, high and low effort activities, reinforcement schedules, simplicity of tasks, goals, how do we collect the data, and how can I show progress objectively? I know the field of OT especially is struggling, because many times the doctors will say, oh, I don't see improvement in this kid. And not only that, but even parents will come back and many times say, oh, I don't see improvement, because we have very short memories. We start with a particular state, child is not able to do this, but, by the time so many weeks and months go by, things get forgotten. So parents don't remember how my child was so many weeks ago. Therapists don't have objective proof that, oh, this is what he couldn't do and now he's doing. But, so we've seen that happen in our clinics, that parents will say, oh, no, I don't see much improvement, so I'm going somewhere else, or I'm going to another therapist. So we want to prevent that. We want to make sure that we prove to the parents that, no, what we are doing is working. And this is how, taking data in an objective manner and showing it to them is going to work. And you can like say, okay, look, when you came, this is what he was doing and this is how he's doing now. So there is no two views that my therapy did not work. All right, so let's talk about our simple tasks, right? So in our sessions, we engage children in all activities, whether it's fine motor activities or gross motor activities or visual perception activities or ADLs. No matter what activity we use, we want to know what the child is comfortable with doing. What does he like? What does not like? And how do we define that preferred versus non-preferred task? Preferred task is something I like doing, right? I like to read, but I don't like to talk in front of other people. So reading is my preferred task, but presenting in front of other people is my non-preferred task. So if I get an invitation that, hey, can you present a 5-minute talk in front of 5 people, I'm most likely going to hesitate and say no because I don't feel comfortable doing that. But if somebody were to give me a book of a short 5-minute paragraph to read, I would do it because I like doing that activity. So when we work with our children or adults, we want to know what are their preferred tasks and what are their non-preferred tasks. And we should make that list very silently in our notes. So that list will come very handy in our sessions. So when we present tasks to them, we can kind of, oh no, he told me or she told me or mom told me that he does not like to do this. So it doesn't mean that I'm not going to present that activity, but it does mean that it's going to affect my session structure and the the way I'm going to run the session to get more compliance, to get more participation, and to get more input from the client. So the other component of preferred versus non-preferred, not just likes and dislikes, but also whether this task is easy or difficult for me. So if I have a speech issue and I'm asked to talk in front of a group of even 5 people or 3 people, I know it's going to be difficult for me. So asking me to do that chore is going to be a little bit challenging. So we just as therapists need to be aware about this particular thing when we are getting started with our clients. Just making note of these few things will help you in the long run. Okay, so now this brings me to another component of ABA, and of course we also do in OT, but there is a different name for it, is pairing. When in OT, we always talk like rapport building. We want to build rapport with the kid, and we do spend some time building rapport with the kid. But there are times when therapists will take a kid or an adolescent, any client, and will jump into starting therapy right away. We don't want to do that. We do want to spend some time getting to know that person and that person getting to know you. Now, this is not psychological. We want to do it in an objective manner. So we use the term pairing to create that relationship between your client and yourself. You remember the experiment we learned in physiology, right? About the dog salivating with the tone of the bell, right? So in that experiment, we know that when the food is presented to the dog, he would salivate, and the experimenter then started pairing food with bell, and the dog would salivate in the same manner. But down the road, what happened was the dog started salivating only at the sound of bell with the food being taken away. So what happened here is that the dog started pairing the sound of the bell with the food. So he would understand that every time I hear the bell, I'm going to get food, and he would salivate. It's the same thing with our clients. So when they see us, we don't want them to think that we are bringing them in to do hard work. They come into the session and we say, okay, let's do TheraBand, let's do push-ups, let's do this, let's do that. It's all hard for them. It's very difficult for them, right? Because they have low tone or they have cerebral palsy, or even autistic kids. So they'll cry and they won't give you that cooperation. So we want to spend maybe a little bit of a time to start pairing ourselves with something that's fun for the kid. So here's where your preference or preferred activities will come in. So if I know what the preferred activities are, or what the child likes and dislikes, I will start pairing myself, bring those activities or introduce those activities to the kid, and start just having a little bit of fun. So when I walk in or when the kid walks into my room, the kid will know that I have some fun things for him, things that I like or he likes, right? So that's the principle of pairing that we all should remember, if we are working, especially when we are working with children, and especially when we are working with children with autism, it's very, very important, very, very critical. So we want to make ourselves someone that the child will look forward to coming to the clinic. And I want to show you a tiny video here. I hope I can make this work. Okay, here. All right. So here is a therapist who has gone home.
Dr. Arora, we are not seeing your video. We are still seeing your slide.
Okay.
Dr. Arora, are
Yeah.
you waiting for us to, are you planning to share the video?
Oh, you didn't see the video? I'm
No, no, we are
sorry.
not seeing any video. We are still seeing your slide number 13.
Oh my goodness. How do I share the?
Yeah, you need just go ahead and click the same share icon again. And then,
Okay.
select the window of the video and also make sure that you include sound in it, because otherwise we'll see the visual but we'll not hear anything.
Okay, so browse my computer.
And then like the same icon that you used to share the slides, click it.
Yeah, but I need to go on my, like the browser.
No, if you just kind of move your cursor on the
Like I want to
team
go to
screen.
YouTube, you know?
Yeah, that's you can do it. So once you have that window open, then come here and then choose the share icon and select the video window to share with us. So first you want to go to your browser and open the video.
Yeah, no, the videos are open. I've already kept it open on the browser.
Okay, so then you go to the share icon.
Yes.
And then if you just kind of see multiple windows, select the window of the video. Do you see the available options to share?
It says screen or window.
Okay, go to window.
Okay.
And then you will see multiple windows that are open on your computer now.
Okay.
And then choose the one. And if there is an icon there that says include sound, make sure that you check it.
Okay, now can everybody see?
Yes, we can see the video, but it's already halfway through. So if you would just want to play
No,
it from
no,
the
don't
beginning.
worry. Yeah. Okay.
Yeah.
All right. Yeah.
Start sleeping at just the right temperature. Proven quality sleep is life-changing sleep. Visit sleepnumber.com to shop now.
Sorry.
After saving with
Yeah, we can hear you as well. So it's all
Yes,
good.
yes. Okay. Okay.
Not start running programs and ask the client to do work right away. If the therapist started running programs and work right away,
can you hear it as well?
Therapist could become associated only with work and demands, which then the client could start to engage in behaviors such as running away from the therapist or crying. Instead, the therapist would use the client's preferred items in the home, such as toys or certain activities, to associate themselves with those fun items and activities.
Pairing could also be used in other environments, such as work settings and classroom settings as well. As a matter of fact, my professor uses this technique in my class. Let's take a look at how she implements it. In this class, prior to starting the discussion, she offers candy to the entire class without any demands placed.
All right, so I have candy now for you guys because you are super great. Go ahead, pass it down.
Okay, all right. So was everybody able to see it?
Yes.
Okay, now I'm coming back to my screen.
Mhm.
How do
The
I go
same
back to
thing.
my?
Yeah, the
Yes.
same thing. Go to the share icon
Okay.
and then select the window and then select the PowerPoint window.
Sorry. This is complicated.
No worries. Just
Okay,
click
okay, hold on.
share icon and then like go back to your PowerPoint window.
Okay, so I see everybody's name on my screen now, and then I go
You're
to
sharing probably your desktop window, and now we are seeing you're not sharing anything. So click share
right,
icon.
right.
Yeah.
Okay, so I go to
Don't choose desktop. Go to window.
yeah.
And then
Oh,
do you see your PowerPoint window?
can you all see my screen now?
No, actually, we're still
No.
seeing you.
Okay.
Is your PowerPoint open? You haven't closed it, right?
No, no, I did not.
Okay, then you should be able to see that as an option when you try to share. Yeah.
You can see it now?
Not yet. So if
Not
you,
yet.
again, the same thing, click share and then click window, and among the windows, choose the PowerPoint one.
Okay, now?
Yes.
Okay, wonderful. Okay, all right. So, so we talked about pairing. We can take questions later, but let me quickly go through the components first, and then in the last few minutes, I can answer any questions people may have. So we also do like a preference assessment, which means like if I don't know what the child's likes and dislikes are, I can present a lot of items during the session and then see where the child gravitates to. Whether he's going towards a ball or whether he's going towards a musical toy or whether he's going towards a book or he was going towards a swing. So watching the child gravitate towards different items in the room will tell me these are child's preferred items. There is one thing I want to bring attention to everybody is that a child's preferred items are usually not the same every day. For some kids, it may be, but not for everybody. So we should just spend maybe 2 minutes in a day, at the beginning of the session just to see where the child is gravitating today. And you will be surprised to see that every single day the child might gravitate to a different item. It's all of us like wanting to have a dessert at the end of the day. Or at the end of the meal. Today you want to have ice cream, tomorrow you want to have chocolate or any other type of sweet. It's the same thing with the kid. They most likely don't like to have the same thing every day. So today, if Play-Doh was their favorite item, tomorrow it could be balloon, or day after tomorrow it could be bubbles. So just keep this in mind when you are starting your session. It will make your life much, much easier. Because I have seen therapists complain many times, like, oh, he likes Play-Doh, but I'm giving him Play-Doh and he's not cooperating. That's because today it is not his preferred item. So we should take this into account when we are starting our session to make our session successful and to make our kids more compliant. And environment. Let's talk a little bit about our environment, which is our therapy room. And we all know what is the impact of sensory component on our child's performance. We talk about it a lot in OT. But I also want to bring it to the attention that, there are some times when we have to really make sure we keep the rooms very, very clean and neat. And I don't mean like physical cleaning. What I meant was taking away all the sensory items or all the physical items from the room. Sometimes we come across kids who are so hyper, who have pretty much no attention span. They are like constantly moving from one spot to another spot. They are engaging in elopement, running away from room. They toss and throw objects. So those type of kids, we pretty much say, let's use a sanitized room, which means that room should be totally bare, totally empty. All items that you are going to be working with should be kept in closed bin, so child has no access to it and he's not going to get distracted by them. And then you slowly start working on getting the child's attention, improving eye contact, listening to you, and on those foundation skills. But this structured environment is very, 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 very important. And also how you position yourself in the room. You want to position the kid in such a manner that, materials are kept away from the kid. You are between the materials and the kid. The kid is positioned in such a manner that he is not looking all over the room. Sometimes you have to make the kid face the wall because of their attention issues. So just be mindful of this component during your therapy sessions. We all come across children who are non-compliant and they don't want to do anything, or they give you a hard time to follow the directions. Those kids, we use the term non-compliance. That's a behavior term, it's not an OT term, it's a behavior term, but we see it all the time during our therapy sessions, right? Especially, as I said, when they want to do something that is very difficult for them. So in those cases, we use something that is known as behavior momentum. Now, momentum, is something that you do at a rapid in the flow of things, right? You're talking and then, somebody wants you to sing. You don't like singing. You don't want attention drawn on yourself. But when the group starts singing, you just kind of slowly join in. That's behavior momentum, because I'm using a technique of building up a momentum to get the child to do a task that he or she does not want to do. So it seems very obvious, but this strategy works so well. An example could be, right, you want the child to clean up and you have all things on the floor or on the table, and you want the child to clean up, and you tell the kid clean up, and the child obviously does not want to clean up, so he's not going to do it. So then what happens is, like with the parents especially, or with the therapist also, a power struggle will happen. And then comes a tantrum, or throwing himself on the floor, or just walking away from the table, or walking towards the door because he does not want to do what you have asked him to do. So we can prevent this type of behavior from happening by using the principle of behavior momentum. So what you do is get into a fun mode and, oh, let's clap your hands. Oh, touch your nose. Oh, touch your nose, touch your ear. Oh, where's your hair? Touch your hair. Oh, let's clean up. And you will see that the child will not even realize that you asked him to do a non-preferred activity. And I just don't mean this for like cleaning up. I just mean for any task that's non-preferred and they don't want to do it. So you just get into that behavior momentum. You keep making him do things that are very simple, easy, fun for him, and in between, like say, oh, okay, let's squat and stand up, and the child will do it. It just works like magic, So it's really a cool strategy that we all can use when we are in the session, and when we want the kid to do something very hard and they don't want to do it. So just try to use this strategy. So this is how you would do it. As I already said, you want the kid to go to the bathroom, and the kid is doesn't want to go to the bathroom. So you won't start with going to the bathroom. You'll just say, hey, Dave, give me your hand, or give me high five. And then if he gives you high five, tickle him. That's something he likes. And then you say, hey, stamp your feet or jump, touch your nose. You are amazing. Time to go to the bathroom. And you'll see the child will stand up and start going to the bathroom. So the trick is to do 2, 3, 4 instructions for very simple preferred task in a fast-paced manner, and then insert a non-preferred task all in rapid succession, without placing too much emphasis on your non-preferred task. all right? And this helps us to build compliance in the kid. So you will go from a child who didn't want to do a task to a child who wants to do a particular task. Token board, everybody has heard about token board, and I'm sure, a lot of OTs are using token board, but this is something I really want to emphasize. Very, 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 very important. It will make your life so much easier during your sessions. So let's understand what is a token board and how it can be used. A token board is like an economy system, right? You want to increase a child's frequency of behavior. So you want to use some methods where you will give him that visual feedback to say, hey, you are on the right track to get your reinforcer. So you can have a simple token board like a laminated sheet. You can put 4 or 5 boxes on it, and then you can have simple stars and say, okay, if you get 3 stars, I will let you play with Play-Doh, or I'll let you play with putty, or we'll play with the ball, or we'll go on the swing. So you are going to have him do cutting. Okay, star 1. You can have him do coloring, star number 2. You can say, hey, let's do 3 squats. Star number 3, hey, good job. Let's go on the swing. Or here's bubble. You wanted to play with bubbles. So the child will see the visual token board in front of him or her, and that would help him to see like, oh, okay, there is an end to it. You're not continuously going to make me do work. These children also have processing difficulties. So we may tell them like, oh, if you do these 3 things, I will give you this. Many times they don't process it, and we just like think like, oh, he knows what I'm saying. But then in the meantime, what happens is the child will do one task and he'll fail, and he'll like, oh, I don't want to do the other task, So giving that token board, keeping it on your table, and letting him see all the time where he is going will make world of a difference to build up the compliance, to get good response, and to get quicker responses from the kids. So use token board for pretty much everything in your session, and you will see so much compliance building in the kid. And token boards can be used not just for compliance building, it can also be used for multiple other activities, like building a communication between you and kid. The child could be nonverbal, right? And he doesn't know how to tell you, stop, I'm tired, I don't want to do this, or I need to go to the bathroom. So we could use like a picture board, we call it as PECs. So you can make some small symbols or icons of bathroom or break or stop or swing or putty or ball or balloon, and you can have it laid out, and you can have the child pick what is his reinforcer today, or what does he want to work for after the item that you want him to work on. And that would make him feel so much in control, that you are not the boss, he is also the boss, that he gets to pick and decide what he's doing. So he becomes your partner and he doesn't become your follower. So when you two peoples are partners, you know that the product or the session will run in a much better way. So use token board to as much as you can. You can even create like a visual schedule for every kid into your therapy rooms. You can create a session for every child, write the child's name on top and say, balloon, putty exercise, or going on swing, or going on the mat and doing the ball exercises. So if you put all those small cards on that visual schedule, and as the child gets that, you just put a check mark on it. The child feels so fun. It's like, oh, I'm doing this. Now I have to do this. Now this is my next task. Oh, this is my next task, And it just helps the child to get into the rhythm and knows when the end is coming. Otherwise, they get upset because they don't know when they are going to finish the session, when they'll be able to see their mom again, or when they'll get to go out of the room. So using this simple technique and strategy, visual schedules, pegboard, or first this and then this, will help you get so much out of the session from your kids. And here comes a definition of high and low effort. We talked about high preferred, no preferred, or less preferred and more preferred tasks. Now, in our sessions, we also know that some activities are high preferred and some activities are some activities are high effort activities, and some activities are low effort activities. Some tasks are easier for kids to do, like doing putty exercises is fun for most of the kids, but for the kids with sensory issues, it's a high effort activity. So we need to categorize what activities we are going to use with the kids into these two categories as well, not just preferred and non-preferred, but also how much effort the child has to put in. For you, playing with putty is a very simple task, but for our kids, it may not be a simple task. Just touching the putty could be a high effort activity, whereas a low effort activity could be just rolling the ball for that kid. So we need to also take this factor into account when you are scheduling your activities into your session. Sometimes it's good to start with low effort and move into high effort, or do alternate high effort, low effort, high effort, low effort activities. It will help to prevent meltdowns. It will help to prevent non-compliance during your sessions. And it goes into our principle of behavior momentum that we already talked about. Okay, so we are already into 8:46. Let me quickly move. Let's talk about a little bit on reinforcement. Very, very important concept. We don't think about it, but we should use this a lot. It does not mean I'm bribing the kid. Reinforcement is not bribing. Reinforcement is using an activity or a thing that the person likes, and it could be social praise. Oh, good job. Sometimes kids get motivated when they hear the word good job. It's a social praise. So use social praise very freely, and you should pair it with a physical activity, like putty or balloon or ball. Oh, giving him the ball and then say, hey, good job playing with the ball. It pairs a social praise with a physical activity, and then you could phase out the physical activity, and just the child should be able to do the work with social praise or social reinforcement. So the concept of reinforcement is very, very important. It's a big, big concept, and it cannot be covered in 1 minute. So I just want you all to remember that reinforcement means something that will increase the probability of a child's behavior. Very important concept. And again, it's like a preferred activity. If the child knows that if you know this is the child's reinforcer today, and if you use that for your session, it will increase the child's probability of behavior of doing push-ups, or doing going on the swing, or doing some jumping jacks, or doing some sit-ups. So be mindful of the reinforcement component into your therapy sessions. And these are all the schedules. I know we don't have time, so I'm going to skip that. Let's talk a little bit about goals. I mean, this is very, very critical. We all do it all the time. It's an important part of OT, PTs, and speech life. We write our goals, and we want to write goals that are very smart, which means it should have these 5 components: who's doing, what they are going to do, when they are going to do, why they are going to do, and where they are going to do. And it should be, of course, measurable, and it should be achievable. Many times I've seen OTs or PTs or speech therapists will write a big goal. That goal can be accomplished in 6 months or a year. Then you continue to work on that goal, and you're not able to show progress. And the parent will say, oh, you started working on this goal, but I see no progress. And you also see, oh, I know he's not making progress. But the child is making progress. So that's why it's very, very important to be very careful when you are writing the goals in your reports. They should be very simple, very measurable, and observable and achievable, and they should be relevant. We should not use goals that are not relevant to that person's life, in that moment or in that phase of life. And it should be time bound. I cannot write a goal that I'm going to achieve in 1 year because I cannot show progress. I want to see what's happening now. Parents want to see what changes are happening now. So we should write very simple, short, very easily achievable and quickly achievable goals. Let's look at an example. And this is very important because we have to prove that my intervention is making a difference. If I cannot prove that my therapy is making a difference, then, everybody starts questioning and then we lose the client. Okay, so here is an example of a SMART goal with very objective criteria. Client who will put on a pullover shirt with moderate assistance with 80% accuracy in 4 out of 5 trials across 3 consecutive sessions. To increase what? For what purpose, right? To increase independence in ADLs. This is a very simple way of writing a goal. I'm not writing with independence because it's going to take me a long time to get there. So what I can achieve in 2 weeks or 4 weeks is what I should write. In ABA, remember in the beginning, I said ABA is very, very objective. This is how they make everything very, very objective. So I wrote the goal of putting on a t-shirt with mod assistance, and I kept my criteria as 80% or 4 out of 5 trials. So I will do a simple data collection on this. I will run a 5 trials, right? We do that during our therapy session. We make the kid take out pull out a shirt, put it on, take it out, put it on 5 times. So every time the child does that, take a data on it. Okay, so first time he does it independently, second time he does it independently. So I mark a plus, plus, plus. Third, fourth time and fifth time he didn't do it, or he needed more assistance than moderate assistance, or he messed it up, something like that. So what is the percentage of performance on 715? 3 out of 5 trials. So it's 60%, correct? Then tomorrow he comes and he does the same activity and he gets a plus for the first time. Second time also gets a plus. Third time he messes up. 4 times he does plus and he gets it correct. And 5th time he gets it correct. Remember, it's not independence. It's with moderate assistance. I'm not grading it on any other criteria other than what's in the goal. So now today's performance is 80%, not 60%. So did I not show a progress in today's session? I showed that yesterday the performance was 60%, but today's performance is 80%. Tomorrow when he comes in and he gets plus, 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 plus for all the 5 trials, I can show that today he performed 100%, which is my first day of 100%. Okay. Next day, if I get 100% or 80%, and then the following day I get 80 or 100%, my goal is mastered. So I can tell the parent like, hey, we mastered this goal because he met his criteria that I set for him, moderate assistance and 80% accuracy. Then I can write a new goal, which will be with min assistance. Same exact goal, but with min assistance. And I will collect the data in the same manner to say plus, 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 minus, minus, or minus, 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 plus, plus. And I just keep track of my percentages, and you can quickly take it by, in your note, and just keep track of it. And you can show the parent like, hey, now he can do with min assistance. Once he masters min assistance in 1 week, go back to changing the goal to independence, no assistance required, and then take the data again, and then you can again say plus, plus, minus, 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 plus, 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 minus, and then plus, 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 plus. And that shows to you, to parent, to your supervisor, and to whoever is paying, if it's an insurance company, that, oh yeah, the child is making progress, to the goals that were set for this particular kid. All right. So this is the key in terms of showing objectivity in our therapy sessions, how we are making progress, not subjectively. What I think is moderate may not be the same as another person. It has to be objective. All right, so these are the most important components I wanted to share with everybody. Let me come out of it. Oh, there is, I just wanted to share this slide with everyone. People many times will say ABA is abusive, it's only for treatment with autism, or it makes children robotic or scripted. It's nothing like that. It is, if used in a proper manner, it brings about a significant change, just like OTPT and speech. It is equivalent to OTPT and speech. It works in the same manner as OTPT and speech. So, you know, let's respect each other's profession and talk good things about each other and bring about change in children. You know, children's lives are very precious, and we want to give the best to our kids, you know, that come to our clinic. All right, so I think I'm done with my presentation. And now I need to
Yeah, just use the same icon. It will say stop share.
All right. Yeah. Hold on. Sharing is paused. Is it paused now?
We can still see your slide.
You can still see me. Okay.
There you go. Yeah.
Okay. All right. Good.
Good.
Okay. Okay. All right.
All right, audience, any questions? We have a great expert here who has multifaceted, who's a licensed PT, OT, and a behavioral therapist. You know, we rarely get to see someone mastered in all fields and professions. So feel free to make use of the expertise and ask questions. We still have about, probably we can just go for another 8 to 9 minutes. Because we started at 7:05.
So can I ask one question?
Yeah, go ahead.
Hi, ma'am. Thank you so much for the informative lecture. I just wanted to know how long would an ABA session be for, usually the duration?
So usually the ABA sessions can run anywhere from 10 hours per week to 20 hours per week to sometimes even 40 hours a week, depending upon how severely involved the child is.
Oh, okay, ma'am. Yeah, thanks a lot.
Yeah.
I just want to add there, when you ask the question, just introduce yourself and say where you're from.
Yes, sure. I'm sorry for that. So, ma'am, I'm Kimberly. I'm from Goa and I'm an occupational therapist.
Very nice to hear your question, Kimberly.
Thank you so much, ma'am.
Can I ask one question, please?
Sure.
Yes.
Yeah. I'm Anita Gupta from All India Institute of Physical Medicine and Rehabilitation. Hello, Kavita. How are you?
Hi, Anita. Nice to hear your voice.
Same here, Kavita. I just have a very simple and basic question. This is about what is your take on allowing the parents to be in the session, you know, while the session is going on. Do you allow the parents to be there, or they should be waiting out? You know, that's a basic question.
I know. It is a judgmental, it's a judgment you have to make as a therapist. There are times when parents being present in the room becomes a very big distraction, and also creation of a lot of behavior issues that happen during the session. So for those times, those children, you should keep the parents out of the session. And bring them in maybe only towards the end of the session where you want to share, okay, this is what I did and this is how the child did today. But there are kids who will respond better when their parents are present. So in those situations, or when the parents are really having good control, instructional control on the child, those are the times when you would want to have the parents present, because you can train the parents so they can go home and do a lot of things that you would want them to do. So it's a judgmental call. Make your decision based on how is the child's performance in the session.
Okay, thank you.
Yeah.
Ma'am, Kimberly here again.
Oh, go ahead. Go ahead, Kimberly.
I'm so sorry to interrupt. Yeah. No. So, ma'am, at what point do you feel that a reference to ABA would be apt? Because consider the session also goes on for a long time. Do they need like a baseline sitting tolerance before, going for ABA? Or at what time after the diagnosis would you recommend to, start
Correct.
ABA?
Correct. So just like in
Hmm.
OTPT and speech, we have made this criteria, right? As if you
Correct.
start if you start the therapies as early as possible, you get better
Okay.
results, right? Early intervention is the best intervention.
Correct,
It's
ma'am.
the same thing for ABA, but ABA usually cannot be done earlier than 18 months to 2 years of age. After 2 years of
Okay.
age, that is the norm here. They will recommend ABA from 2 years of age. That's their bottom line. And now actually they are making it 18 months as well. So again, referring
Okay,
for
ma'am.
ABA is also should be done as early as possible.
Okay, ma'am. Yeah.
Yeah.
Thank you.
Nafisa, I see your hand. Do you have a question?
Uh, yes, sure. Hi, this is Nafisa Hussein. I'm from USA. And thank you for the wonderful presentation. I just wanted to ask you, in your experience working with younger children, did you find that ABA is more effective with verbal or non-verbal kids?
All kids. All kids. It's
Okay, there is a
effective with all kids, verbal, non-verbal, with behaviors, without behaviors, with echolalia, without echolalia. It's for everything.
Would you say that it's more effective with non-verbal kids, or it's
No.
same?
It's for every kid, because every kid has, whether he's nonverbal or verbal, there are issues where if there are issues, like, see, it's almost like asking me a low tone kid, or a normal tone kid, right? Whether OT is effective for low tone kid versus no tone kid, right? It depends on what the deficits are or what the issues are. If a low tone kid is functioning well, is able to do everything well in life, they will probably not come to you. But if you have a verbal kid or a non-verbal kid but has deficits, or has behavior challenges, or has behavior rigidity, you need to work on those, right?
Thank you.
Yeah, sure.
There are a few questions in the chat box. The first one is, what could be done for thumb sucking in 10-year-old child?
Yes. So over there, I know we can look at it from a sensory point of view also. Is the child trying to get, is it being done as a sensory seeking type of behavior, or is it being done as a non-compliant type of behavior, or is he doing it because he wants attention of the parent at all times? Like, okay, because if I put my thumb in my mouth, my mom is going to come and pull it out, or somebody's going to come and pull it out. So there are multiple reasons why thumb sucking is happening. So we do need to find out what is the reason, and based on that reason, we would take a path of how to address the thumb sucking.
Got it. And could you please tell about the effectiveness of ABA in stereotypical behaviors?
Oh yeah, it works very well. It works very well. And the one of the most difficult things to take care of is vocal stereotypy. Most of the other stereotypies we can work, vocal stereotypies are very hard, very challenging to work on. But it does work with, it does help in reducing the intensity of the stereotypical behaviors. It may not go away completely, but it does help us to reduce the frequency or the intensity or the magnitude of that particular stereotypy.
Got it. So the next question is, I've seen ABA therapists using food like sweets, biscuits, chocolates as a reinforcer. How helpful is that?
Yes, there is no harm in using food as a reinforcer as long as it is a reinforcer for the kid, but only for a certain period of time. And I want you all to go back to my slide where I said you pair, right? So you pair whatever reinforcer you're using with social praise. Okay. And over a period of time, we want to phase out the tangible or the edible reinforcer with social praise. Okay, so using edibles is not an issue. It's just like how long you want to continue to use it. And plus you have to be mindful. Hold on one second. You have to be mindful of the type of edibles you are using. You don't want to use candies over a long period of time. You don't want to use unhealthy foods over a long period of time. So it may be used as a reinforcer only for a certain period of time. And your goal should be how I can phase this out with more appropriate reinforcers.
Okay, so we have several questions. Do you have 5 more minutes? Because I see like a few more questions in the list. Yeah.
Yeah, I'm here. Yeah.
Okay, great. So does ABA have enough scope in adult psychiatric questions?
I'm not an expert on that, so it would be hard for me to answer that question. I know people have been working on that particular component. There are some people who work with adults as well for behavior challenges. So that's I'm not an expert on that, but I know there are people who do work on adults with some behavior challenges.
Next one is, can we use ABA in Down syndrome children?
Oh, yes, of course you can use. Of course, as long as there are behavior challenges, you can use ABA with anybody. It could be even a normal kid, it could be even a normal kid. Like, there are times when kids are like having multiple temper tantrums or they are picky eaters or they have toileting issues. So in all those kids, we can use ABA. There is no question about it.
Got it. So the next one is from Kimberly. As given, usually autistic children are referred to OT. Is there any criteria for the behavior seen to be then referred to ABA, or every child, regardless of the intensity of behaviors, would be referred to ABA?
I would suggest every child with behavior issues should be referred for ABA. And then let the ABA therapist decide whether it is appropriate or not. But it's good to just have a pair of eyes, take a look at them, and then, they can make the decision from there on.
Got it. So this is the last one, I guess, in the chat. Can you please tell us how you will work with autistic kids with olfactory seeking behaviors?
Well, 1 minute is not enough. So that's a long question. If you want to talk to me about it, you have my email. Reach out to me and I can definitely connect with you to talk to you about the protocol for that.
Got it. And then this is also a similar question along with Down syndrome. So can ABA be used in patients with intellectual disabilities?
Yes, you can use it. Yep, absolutely. Yes, and I'm going to type my email. Is it okay if I type my email so that anybody with any other additional questions can reach out to me, and I'll be happy to answer those questions for them.
Definitely, yeah. So one final question. Yeah, we see your email. So please, going forward, because we are like maxing out our time, so please go ahead and send your questions via email to ma'am if you need an answer. So one final question before I let you go is, like, I thought like this would be benefit for the folks here. What is the difference between negative reinforcement and punishment?
Oh, okay. See, punishment is something that is used to reduce the frequency of behavior. Reinforcement is used to increase the frequency of behavior. So whether I use positive reinforcement or negative reinforcement, the purpose is to increase the frequency of that behavior. But punishment is used to decrease the frequency of behavior.
Yeah, thank you. I mean, I thought like if it comes from from you, I think it would be more validated, and a lot of people have this discussion. Yeah. That's the reason.
Yeah.
Anyway, all right. So, ma'am, would you like to provide the vote of thanks?
Yes.
Jyotika, ma'am.
Yeah. Hello. I hope you can hear me.
Yes.
Hi, Kavita. Yeah,
yes.
Kavita, we missed you actually. You were supposed to be there for Kote program. I think it was on ABA during Mumbai conference. and at the last moment you could not come.
Oh yeah, I had issues with the flight.
Yes.
I remember that. Yes,
So
yes.
good. At least now people could, hear you today, and it was one, and that was for a longer time. I wish you could have organized for a longer time, but anyhow, there is no limit for the lectures. You can keep on taking.
Absolutely. Yeah.
In depth, but it was wonderful lecture of Kavita, and Kavita has been always wonderful. Like whatever topic you give her, because you said she's an OT, she's an PT, she's an ABA. I think the speech is only remaining, so which because continuously you have been seeing OT PT speech, so you can also finish that graduation.
No, I'm not going back to school anymore.
So it's just jokes apart. So wonderful it was, and it is good to have so much of a knowledge, so you can combine all those things and your experience and all. It's so vast. I remember Kavita from All India Institute, where she was working in Mumbai, and that experience is very different than what she is today. What is wonderful. I think you all the guys are very lucky to have Kavita today here for her lecture. So on behalf of international branch of ICAIOTA, and also the Indian branch of ICAIOTA, and also the Academic Council of OT Association, I thank you. Thank you very much for accepting our invitation, and you are there today on Saturday, the weekend, which Dr. Vijay Supple always organizes it. I always say weekend is for the families, but anyhow, hats off to you people being at I think it's a very odd time at your place, but whatever it is, you have been doing such a great job. And Kavita, you have really done a great job. And I'm sure I'm going to organize one more on ABA, more time and more details. We can go and I will definitely send you a proposal. And I really loved it. I really loved it. Thanks a lot.
Okay, sure.
Dr. Vijay Supple, Dr. Karthik Mani, Dr. Ghazala, and all my friends who are attending today, Anita Gupta and others. So because I could only hear Anita Gupta today. So Anita, thanks a lot for attending, and thank you very much, Anita. Oh,
Yes.
Kavita. Thanks a lot.
Yes, thank you. Thank you very much. It was good to connect with the OT group today.
Yes. Thank you.
And I'm here anytime, if